So welcome back to the second half of this session on ethical issues in decision making. As you can see, I've got a very distinguished panel up here on the stage with me. You met Dwayne and Wei Ling yesterday, so I won't introduce them again, other than to say we're very delighted to have you back on the second day, and thank you very much for participating in this panel. And on my left, of course, we introduced JJ yesterday. Yesterday. Oh dear. Well, he was here yesterday, just not up on the stage. We introduced JJ earlier when he gave his excellent talk. And now on the panel, we're joined by Philip Yap and Jason Fu. Now, again, I'm going to put these glasses on to do the introductions properly so I can read. Okay, so Dr. Philip Yap is a senior consultant geriatrician and palliative care physician in the Department of Geriatric Medicine at Khoo Teck Puat Hospital, and he's also an adjunct associate professor with the Yonglin School of Medicine at NUS and LKC, as well at NTU. His interests are in dementia, long-term end-of-life care, and the support of caregivers and care partners. And next to him is Mr. Jason Fu, who is the Chief Executive Officer of Dementia Singapore. Some of you probably will know that it was set up as a social service agency back in 1990 as a result of the growing prevalence of dementia in Singapore. So their vision is to build a dementia-inclusive society in Singapore, and so they run a series of programs and services in relation to dementia. So Jason's also been on the board of Alzheimer's Disease Association, and he was a volunteer for 22 years before taking on the role of CEO. In his previous life, he was a chartered accountant by training and worked in senior positions in banking and finance before moving on to this role. So would you please join me in just giving a round of applause to the panel members. Okay. So if you don't mind, let's rock and roll and move straight into the first case. Oh, glasses. Right. So I am going to read it aloud, though obviously it's up on the screen behind you as well. So, preparing for advancing dementia in a loved one at home. Madam Cho was diagnosed with Alzheimer's disease 8 years ago. Smita, a migrant domestic worker, has lived with Madam Cho in her HDB flat for several months. Madam Cho's daughter, Serena, an office administrator with 2 teenage children, supervises her mother's care. She has stopped by the flat today to see her mother, who now rarely speaks and no longer recognizes her. This font is bigger, that's why I don't need my glasses, in case you're wondering. Serena finds out from Smita that Madam Cho has difficulty eating lately, taking a few bites and then refusing any more food. Serena leaves instructions to Smita to prepare Madam Cho's favorite foods and to cut the food into smaller pieces. 2 weeks later, Serena is back at her mother's flat after receiving a text message from Smita that Madam Cho has refused food for 2 days, spitting out any food Smita tries to put in her mouth. At the flat, Serena tries to coax her mother to eat, but Madam Cho stares into her lap silently. In desperation, Serena tells Smita that she needs to get back to the office and that she has hired her to take care of these problems. That night, Madam Cho's breathing becomes unstable, and Serena calls for an ambulance to send her mother to the hospital. Okay, so we've got a number of questions for you, which hopefully are going to appear on the screen now. When we're looking into, and the questions relate to what decisions Madam Cho's daughter may face as the dementia progresses, the reasonableness of expecting informal care partners to fix care challenges, and the healthcare system's obligations to Madam Cho and her caregivers at home. And the second question relates to how should caregivers of persons diagnosed with dementia be prepared to make surrogate decisions, and how will the authentic wishes of a person with dementia be respected in practice? So, before I engage with the members of the panel, I'm going to put this out to the audience, and I know you've been very active and participative, so I'm certainly hoping that's going to continue for this session, right? Because otherwise I will arrow people. No, I'm just kidding. But maybe I will. Let me throw it out there as a question to all of you. When you see this case scenario, what's going through your mind from your perspective, whether you're a healthcare professional or a care partner, in relation to the situation that this family finds themselves in, and how you might be able to move forward in relation to best supporting them? Anyone want to share some thoughts or pose a question to us? Yes, please.
Sorry, my name is Elizabeth. Actually, this scenario is still very fresh in my mind. I went through it personally. Yeah? My mom had dementia, and it was exactly the same circumstance where she refused to eat. But when I went one step further, we started to puree the food, thinking that she couldn't chew. But she still couldn't eat. And this went on, and she had fits. Yeah, it ended up with fits, and I rushed her to the hospital. And this happened twice. Yeah? And finally, I was told that she lacked nutrients that was causing the fits. So I said, but Mom refused to eat, so what can I do? So in the end, she ended up having a tube fitted in for me to tube feed her. So it's something fresh in my mind, and I always ask the question, why wasn't I told of this earlier? Why wasn't it told to me that as Mom's dementia progresses, this is how she will end up to be, or how can I prevent this from happening? So I leave the audience to inform the rest of us who we hope will lead a better ending than what I had with my mom.
Thank you very much, Mrs. Sia, for sharing that. I mean, that, again, very relevant perspective and experience that you've had. Now, I'm thinking of posing this question. JJ is like, I've spoken enough for today, and he's looking at Philip, like, Philip, you can take this. So maybe I'll give JJ a break, and I will ask Philip. So just to give you a heads up, I'm going to pose the sort of more clinical aspect of it in terms of communication and supporting decision-making with, the person with dementia and their care partners to Philip. And then, Jason, I'm probably going to follow up with you and ask you about what role an organization like Dementia Singapore would have in terms of trying to help families prepare I don't want to say work optimally, but how can we best discuss and manage concerns of the family in relation to preparing them as the person with dementia progresses in their condition? So Philip, first, if I may pass the mic over to you, what would your advice be in relation to this communication and decision making leading up to a situation such as that described by Mrs. Seah?
Thank you. I think it's the obligation of healthcare professionals to provide an overview of the general trajectory for a person with dementia at the different stages. What are the issues that may arise, especially in terms of the deficits that will come in early stage, in moderate stage, and in late stage disease. But quite often, I must say that we also may not emphasize enough on the remaining abilities of the person with dementia, despite progressive disease, and how you can help to relate and connect with them better. Now, specifically with respect to the issue of seizures, I think JJ and the doctors in the audience will perhaps agree with me that while it's not uncommon, It's also not a very typical symptom that we would mention right at the beginning, right at the outset, no, when we share a diagnosis of dementia. Usually not, no, but although it's something that can happen. So I mean, after hearing your account, my first thought was, is this a stage-appropriate symptom or a problem? If a person has early dementia or even moderate stage dementia and something like this happens, it could happen to any person. So then we then have an obligation to do something about it. And if it's because of a salt problem, maybe it's sodium or magnesium, then that can be corrected first. And then how do you therefore ensure adequate nutrition and hydration thereafter if the person is not able to eat or drink sufficiently? At that stage of the natural history of the person's dementia. If this is very late stage dementia and this is something that is consistent with the natural history and trajectory of the disease, then we would enter into a conversation as to whether it is prudent to pursue tube feeding or not. And sometimes we offer time-limited trials, whether you want to give it a try and see how the person takes to it, how the person's quality of life may change with the tube, so on and so forth. Yeah.
Okay. Maybe I'll start off by saying that for Dementia Singapore at least, we always advocate for aging at home, which means aging at your own home with family members, people you're familiar with, in the community that you're familiar with. Of course, in this case, I just wanted to share that it's a little bit, it's not very ideal because I know this happens quite frequently where families get a helper and then just let the helper take care of the elderly with dementia and leave them in a home on their own. I think it's really, coming back to the case study at least, it's not very fair to place this burden entirely on a helper. And when I read this case, it depends also whether the helper has been with the elderly for a long period of time. There are some that are very familiar. The helper has been there for 8 years, 10 years, even before the person had dementia. So the helper is very familiar with the elderly. Elderly is also very familiar with the helper. But for this case, the helper only was engaged like several months ago. It's a new helper. But the person with dementia has been there for 8 years. She was diagnosed with Alzheimer's for 8 years ago. So it's not, the helper came in only recently. It's going to be very difficult for a person with dementia to adapt to someone new like that coming into their home and trying to care for them. There's going to be a lot of tension, a lot of difficulty in adjusting. So for us, actually, I know JJ spoke about care partners' dreams, people giving up their careers and their dreams to care for their family member who has dementia. But sometimes that would be the ideal situation, that when someone in the family has dementia, someone within that family changes their life or gives up a dream to take care of a person with dementia. That I can only say that is ideal, because it cannot happen all the time, as what JJ said. Sometimes it's not possible. Of course, if it's really not possible, then personally, I won't advocate for just getting a helper and sending mom or dad into a flat and just leaving them there and hoping that the helper can cope with the caregiving, because I think that will not work well. Maybe mom or dad may be better off in a nursing home where there's proper care, if really the caregivers cannot provide the care at all. Yeah. So ideally, yes, it's someone in the family giving up their dreams, changing their lifestyle to care for the person within the family. Ideally, it can be a flexi work arrangement that you can work out so that you can still continue to pursue part of your dreams or some of your dreams, but still be there to supervise the care for the person with dementia and not leave them in a flat and say, you take care of everything. It's just really not, I mean, to me, that's not appropriate. To the question from the floor on a person with dementia not wanting to eat, which is also in this case study, I think sometimes it's not it could be due to a unmet need. Sometimes when we see certain behaviors in persons with dementia, unfortunately, they are not able to tell us what is it that they are upset about or what they are not happy about. So this not eating is not because they don't want to eat, they are not hungry or whatever. It's just something that is bothering them, and that is that causing them not to want to eat. So if you engage professional help, someone, a trained person from, let's say, Dementia Singapore or somewhere, or working together with the doctors, we could actually try to see whether we can figure out what is it that is bothering this person that is making her not want to eat. I won't say that we can always be successful in finding the trigger as to why, but there have been cases where we have managed to find the trigger, and once the trigger is removed, the person can then go back again to eating. But if all fails, then I think Philip is right. You then have to resort to tube feeding because there's nothing else you can do. But I would say that my view is let's not go straight to tube feeding. Let's see what is it causing. Can we figure it out? If we can, that would really avoid the tube feeding. Because I can just imagine a person with dementia having a tube up her nose. It's just going to be very, very difficult. They don't understand. A lot of times a person, people without dementia, if you explain to them this tube feeding is necessary because you need to keep you going, it's just to bring nutrients into you, they can understand. But for a person with dementia, that explanation cannot, it's not going to work for them, and so it's difficult. So yeah, that's what I thought I wanted to share. But for caregivers, I always say, you are thrown into this caregiving journey, not by choice. So you just have to figure out how to cope with it. But there's a lot of help available now outside, whether it's Dementia Singapore or many, many organizations that are supporting people with dementia and caregivers. But there's a lot of help available. Just you need to look for it. What is sad is a lot of times caregivers don't know where to look for help and where to look for support. Because without that care, that help and support, you're going to struggle. It's going to be a long struggle with the caregiving. I've always shared with AIC, the Ministry of Health, that caregivers need to be supported if you really want people with dementia to age at home. You just cannot expect caregivers to be able to cope with the caregiving and just do it on their own, because it's not going to work. It's not going to be sustainable. So help is there and help is available. Look for it, and hopefully that caregiving will be more manageable. Thanks.
Maybe I'll just add a little bit here. I think first of all, with regards to the helper, I think some years ago, when I had time, I used to have these conversations on a one-to-one. I sent the family out to talk to some of these helpers, and I remember one helper particularly, who was very stressed and almost crying, and I asked her why. She said that, when they recruited me from Indonesia, they told me I was there. I'm coming to Singapore to wash dishes and mop the floor. But the day she arrived, she was brought to the hospital to learn NG tube feeding and catheter care, urinary catheter care. It totally freaked her out, lah. Yeah. So I think but I've also seen in the course of my career some excellent, very experienced helper. So sometimes I wonder whether as a credible agency, Dementia Singapore can actually credential, give them, with their experience, certain badges that they have been trained, and then maybe they can demand a higher pay with the next employer. Yeah, because it is a very valuable asset. I think a very valuable resource, and you can only sometimes wish for this kind of experienced helper. The other thing about helper I want to mention is also that I remember there was a case where the person with dementia keeps coming back for aspiration. Not the kind of aspiration that Emily has brought about, but the aspiration where the food enters the lungs. And I look at the helper, she's actually a very competent helper. So again, I had a one-on-one chat with her and asked what's happening. And she tells me that, yes, I know I'm supposed to, because I think this family opted to do oral feeding. And so, as you know, oral feeding takes a lot of time. But she said that, I need time to do the oral feeding, but I'm also told to wash the dishes, clean the floor, do the laundry and all that. So I could imagine she was probably had to do the oral feeding in a speed that was not very safe. So I think we also have to take into account, put ourselves in the shoes of some of these informal caregiver providers that, are we asking too much? Are we asking the impossible? Sometimes in the moment of stress, care partners would just delegate a lot of these chores and responsibilities to the helper, but actually, at the end of the day, domestic helper, and some of them suffer from insomnia because in the daytime they have to do the house chore, in the nighttime they have to sleep with the patients with disturbed sleep cycle, and then the next day they have to work again, and I think, it's almost inhumane when you hear some of these stories, and that I have to then pull the family down and said, but they will tell you that they either the Ministry of Manpower won't allow them to have a second helper, or they just don't have this room for a second helper. And this is where sometimes, we really have to decide, how these are challenging issues. I also want to make a comment about swallowing issues. Yeah, I think sometimes the warning signs, what I usually tell families that as we move towards the latter stages, if there are some, it often starts off with a bit of choking with fluids. Yeah, they rarely choke on solids, but it's usually the liquid because these are neurological sort of dysphagia. And then we come to difficult, sometimes the point of whether tube feeding is really necessary. I think the first part is really to exclude any acute reason that's reversible for the anorexia, the refusal of food. But many of times it's a very common final endpoint where they develop swallowing impairment. Then there's a difficult question about tube feeding, and there's a lot of anxiety because, particularly in Chinese families, they say, how can they be empty stomach? But the more acute one is, what about medications? I can't get the medication in, what do I do? And a lot of times the need for tube feeding is there. But for us, a lot of times, if it's a long-term issue, we would try to persuade the family to go for a procedure to put in a PEG. Yeah, and with a bit of what we call pleasure feeding. Yeah, particularly in the context where they will tell you, but my father loves food, Yeah, and so these are not easy decisions, but it requires, like I said, the caregivers to participate. And as I've said, a lot of times caregivers are under a lot of psychological pressure. Many a times I find that the daughter caregiver feels that she's under a lot of pressure because whenever the patient gets admitted to the hospital, there is a kind of like, hey, how come you didn't take good care of Pa, that kind of question, and they feel a lot of the kind of pressure on them, and that's where I think as a whole community, we need to help them. There's a lot of communication that's needed. Yeah, I'll just stop here.
Thank you very much. Yes, we have a question or a comment.
Actually, I'd like to share 3 points just to add on to what has been shared, if that's okay with everybody. It's me, I'm Michelle. As you know, I care for that lovely man over there. I'm a care partner, I'm not a caregiver. I'm a care partner. And what that means is empowering him because he's still at that stage where he can make decisions. So we are in partnership in this journey. So one thing about giving up my dreams, I will make a comment to that. Sacrifices are made, but I'm still living my dreams. I have had to make choices, but that does not stop me from going for what I want and still loving it and making it work. Does it take extra effort? Probably it does. But it's also enjoying the journey as well. So that's one. JJ spoke about helper. We always have to remember a helper is there to help. They are not there. They're there to look after the household, but that's where their capability ends to a certain extent. With cognitive abilities, you cannot expect a helper to match our cognitive abilities. We're all very educated and we've been blessed, but they come from areas where they are probably not as educated, because if they're educated, they wouldn't be doing what they're doing. Hence, the expectation around that is that we educate them about what the condition is, whether it's cancer, dementia, right, and set the expectations. And I've always set the expectation, and I'm still very much involved with my father in the care and activities that will help him and support him cognitively, which a helper may or may not be able to do because they need to be educated around how the brain works. Yeah? So with that, helpers then need to employers will need to understand what the expectations are. It's not just to leave our loved ones, because sustaining the condition, in this instance, dementia is very important, means sustaining cognitive abilities, which a helper can sometimes do and not. So I make the helper play games with us, because there's only 3 of us and we need a 4th person to play the games. But other than that, you must understand that there are limitations in their capabilities. So my agreement with her is my dad comes first, the household is second. Yeah? So if he needs to go out and do some errands, she goes with him where necessary. So I think we need to manage the expectations around that so that they are less stressed as well. And it's always reminding them that it is not the condition, it's about the person. So my father reacts, sometimes he'll tell the helper, go away, go away, go away, sometimes, yeah? Not very often. And then she'll tell me, oh, but Gong Gong asked me to go away. And it's educating her that it's really dementia at work and not the person in himself. And educating, now not everybody's like me, spend time educate, I get that, yeah? But it's sharing like this that's important, managing expectations with the helper. And then, so the first point was around living my dreams. Second, as a care person, care partner. Second is about helper. The third point is, I think as a care person, right, in the system, we need to make the ACP, Advanced Care Planning, elevated to our attention, right? Apart from the financial and all of that, ACP is very, very important. So early stage, my dad did not think very much of it, all right? And then, so that's what I mean by surrogate decisions, right? So it's the LPA in place, the ACP. So, and his decisions may change. And my plan is to just, work with him on a yearly basis to say, has it changed? While he still has his capabilities. Yeah. So those are the 3 things I wanted to just add on. Thank you.
Thank you. Thank you so much. Can I please pose a question to Dwayne and Wei Ling, right? Because we've been talking about quite a number of things, but, I suppose one of the threads that underlies everything that we've talked about so far has to do with communication and sharing decision-making. So from your perspective as a care partner and a person with dementia, how would you like to see the process of decision-making work in the most optimal way for you when you are sort of communicating with the healthcare professionals? Because, there are quite a lot of them here. So, well, I think we'd like to hear from you what you think about that, if you may.
I can start. Okay. So maybe I touch on a little bit when I asked Emily about what happens when she goes to the doctors during her follow-up. I will tell Dwayne before we see the doctor, you should prepare questions that you have, okay? And Dwayne's condition is different from Emily, of course. Everyone's different, okay? The patients are different. Emily is quite exceptional, and there are some who are like that as well. So Dwayne has Alzheimer's disease, so it's memory that he has issue with. So of course, he cannot remember, right? And it takes time for him to process information, okay? So it will take days before, meeting the doctor that I will start, we have a meeting, we do a weekly schedule of what we're doing. You are meeting Dr. Adeline, you prepare questions, and also in our Voices for Hope program, we have those kind of goals and asking question. What are the questions you ask your physician? Not just for a person with dementia, for me as well. I tell you, I go to a GP who I like, I chit-chat and I forgot to tell actually what are my problems, So actually I have 3 problems and I just say, oh, I'm coughing. Then later after that I say, oh, actually I have some food problem also. So preparation is important. So he will write down, and I'm happy to say that, he's also seeing psychiatrists. He asks, how do I tell I'm getting better? And then I noticed the physician actually look at him now to really talk to him. Because I don't know about you guys, but very often the doctors look at me instead of him when they talk, when they're, when he's consulting them. So I will just look at him and I refuse to look at the physician. And now he started asking a question. The physician looks at him. And then, of course, then he has to digest a bit. And after that, I say, how do I know if I'm going down? So there's an interaction, empowerment of the patient. And at this point of time, he can make decision. It might be confusing for him to have so many options, and, we have the ability to go round. So it's very simple. Would you like to have hor fun or chow fan? 2 points. And he can tell you, and, for example, make it simple for them. The ACP is something that I just learned, okay? And for me, who doesn't have condition, I heard about LPA already in 2017 or 2016. My friend said, oh, you can go, doctors pay $50 to get that, and then it's free to, the government is paying for the submission, all that. It took me 4 years when when he had this situation where I had to do the LPA. So it's very often like that with us. So I think it's good time we start ACP, and because of this conference, and we started talking about that. And it does take time. Educating, getting informed as a care partner, I can't do it on my own. So that's why we go to like Voices for Hope. We have social club. I joined a Caregivers Alliance. So we have a caregiver. Sometimes I just need to be away, okay? I need a respite. And he, the other day, told me, sis, if you need to do things on your own, you just go, don't worry about me. Because he thinks about me too, but he doesn't articulate, right? Yeah, he still has his humor and a lot of things. So that's why the stigma is dementia is my grandfather, my grandmother, and then in late stage. And then, they can do a lot. So we want to focus on their capability. And just allow me, we are starting an employment special interest group, and we want to look at the capability of PWDs and also their care partners. So like aspirations you were talking about for the care partners, those who are working, sometimes they can't take time off. And we have a fellow couple whose her company is very understanding. So she takes Tuesday off every week to go to the Voices for Hope program with her husband. So not just the capability, employment opportunity or rehabilitation, work rehabilitation. Someone asked how to slow the progress and all that. And the fastest to get them down is take away the social connection and let them do nothing. That is the fastest, okay? And so and also the care partner. Then you look at this too. And very importantly, care partners are not just the intimate ones, the close ones, the friends, the community, and the professionals are very important. So I'm very glad, shout out to Dr. Adeline, who is starting this rehab. Her team, they secure a private donor. So we're looking into that for them to help support us in our quest for the special interest group for employment for dementia.
That's all.
No worries at all. Well, you know, we do have clinicians who are experts at communicating with you know, care partners and persons with dementia. I mean, I don't know whether Philip would consider, you know, not quite modeling what a good conversation would be like, potentially with Dwayne. Would that be something you would be open to?
Why not?
Very good. So shall I pass so I'll just be the mic runner between the two of you, all right? So shall I let Philip kick off?
Okay, I wasn't prepared for this. Okay, we've been talking about advanced care planning. I think we see the value and relevance of advanced care planning, especially for people with dementia. Maybe we can talk about that if that's okay with Dwayne and Wai-Ling. Okay. Yeah, so I think first I would start off by trying to explore Dwayne's understanding of his condition and then the implications, you know, of what dementia can bring in the days ahead. So maybe, Dwayne, I think you understand that you have been diagnosed with this condition of Alzheimer's disease. Yeah. So I just wanted to ask you, you know, how you feel about it and whether you know, or maybe you can share with us, what are some of the problems you have with dementia and of the Alzheimer's type? Some of the daily difficulties you have. Yeah, what change this might be from what you used to be able to do?
Basically, I have no problem doing any other things, but of course there are certain things sometimes you will have some memory problems. Yeah, then you won't be so as fast as when I was better those days. That's why I'm just the early stages. So at this time, I'm still quite all right to me. But of course, can be better. Yeah, that's all.
Thanks. Does it then affect your day-to-day life? You know, does it impact what you want to do? For example, planning, you know, your day.
Planning, but then I can be alone at home. I can go out alone. So I'm still the early stage, yeah, in a way lah. Planning is a bit more difficult sometimes.
You can hold on to that.
Okay. Yeah. So maybe Dwayne, then should we take this a bit further, or are you comfortable with that?
Would you be okay to take it a little bit further? I can hold on to the mic for you if you like.
No,
You're okay?
You okay?
Oh, I'll hold on to it. Okay.
Okay. Yeah. I wonder if anybody has shared with you about what can happen in the days ahead. You know? That with time, perhaps, you know, now you might still be able to, say, be safe alone at home. But say if your memory deficits they get worse, and perhaps you might switch on the stove and forget to turn it off. You know? Or you may go out of the house and not bring your keys. Or you might even, say, go to the neighborhood and lose your way. So Are you aware that these things can happen to you? And,
yeah, actually, this kind of things comes to mind quite often. So I try not to do too many things because I know that I'm still influenced by the disease.
Okay, okay. So if one day something like these problems happen, so maybe I would like to ask you, would you be okay if then and your sister says, you cannot turn on the stove, you cannot cook for yourself, and maybe she would say, when you go out, I would want you to carry a GPS tracker so that I will know where you are, in case you get lost or if you fall down, at least I can track you down. Would you be happy with somebody doing this to you?
I will actually try to, be more healthier rather than to have a GP, things, because you can still lose your GPS or whatever you call that. So, so the thing is at the moment I'm still in quite stages, good stages, rather than falling with my sister, just my sister, because she's sick of me following her, you see. So, so I guess at my stage is still not too bad yet, but then yeah, you never know, you see.
Yes, yeah, I can understand where you're coming from, but if something like this does happen, whereby maybe you get lost once, right, and then and we're afraid that this might happen to you again. So if you were to plan forward, plan ahead, would you be okay if your sister offers to do this for you, that she will, at least be able to watch over, if necessary, if you should get lost or you don't come home after a certain time, that she would be able to know where you might be so that she can locate you. Would this be something acceptable? Your sister is somebody you trust, isn't it?
Yes, I do.
So I'm nudging.
Yeah. So I think right now it's still not that bad, but you never know. You got to plan ahead.
Sorry, I'll intervene. So should you go in? So should your condition become worse? Would you allow that? That's what I say. Yeah.
I think that if it get worse, I will have to take any ways to be better lah.
Okay. Yeah. So you would be okay or open to your sister being able to locate you with a GPS tracker? Yeah. You would be okay with that if the need arises in the future?
I think I'm not that stages yet.
Not at that stage yet. Okay. So maybe
sorry, I'm going back again.
Yeah, we can revisit that next time.
Yeah.
So we pace along. We accompany and we pace along. So I think maybe this is an example of a conversation we could have, and I think the issue really is dependent on, first of course, how much the person wants to know. I think, if I may comment, I think Dwayne has the openness to know what can happen with time. But of course, with that understanding and appreciation comes the willingness and desire to plan ahead and to allow certain decisions to be made in advance. And that can be sometimes a bit more, not a bit less straightforward, right? Because these are not trivial issues. And sometimes when the person is not fully prepared, then we might need to revisit the issue again. But of course, with dementia, the issue is that we only have a narrow time window, right, during which the person is still mentally competent, so to speak, on certain matters. So there's also time pressure that we have to contend with. I hope this provides some example of what we could possibly do in a conversation on planning for the future.
Yeah, no, that's excellent, Philip, and thank you to both of you for engaging with that. Now, I think I did see a couple of people with questions. I think there was one on that side, but for now, okay. Yes, shall we take your question, please?
Okay, I'm Jing. I'm a family physician. So I have a few points. Firstly, if there is the Emily is the -5 SD of a person with dementia, then that lovely sister and the lovely daughter in the audience here today are the -5 SD of caregivers. Because most of us, I believe, are from public health institutions, and for our regional or some international audience, we are very reliant on foreign domestic workers. And I believe that Jason is not ideal, but necessity, be it dementia, frail elderly, those with chronic conditions and organ failures. So I think if we have proper education and proper matching, the foreign domestic worker can actually be a very good carer. Because like for example, I have a patient who is very well cared of by the helper, and in fact, when it's her working days, the patient uses less antipsychotic than when the daughter takes over on her off day. But we can't blame the daughter. She has no options because she has to put bread on the table for her family, take care of her children and all that. So she has no option. She can't actually go and chase her dream. She just has to be on survival mode. Now, so that comes to, so we have, again, caregiving, what do you call that now? Prof. Jing, my illustrious classmate, the excellent, the good, the basic, poor or none, right? So I think we need to be mindful of the persons with dementia's children, what struggles they are facing with, and how are they able to provide basic care to good care. And then maybe the rest of us supporting them can put that care from basic to good or good to excellent, right? Your next level. Okay, so now I'll cut myself short. So I think all of us, when we talk to our patients and caregivers, be whatever conditions that they face in the long term, I think mending fractured relationships is very much a part of my job as a family physician, where I can heal some rifts, where I can clear some long-standing misunderstanding or just bridging some gap that will also help towards improving the care that is not just out of duty, but out of love. And where duty and love meets, there is grace. Okay, finally, second last point. My aspiration is that we talk more about death, because death is also very much in terms of ethics, I think dying well comes in as well. And a lot of times, because of the way our medical care is structured, if we don't talk about this early enough, if we don't get caregivers to be comfortable with how to face death and how to manage death, then most of our elderly are not going to die a good death. Okay, finally, I do a bit of self-koyok, Ken. So I'm with the GRACE program under Psychological Medicine NUH, Geriatric Outreach Assessment, Consultation and Enablement. And it is my firm belief that by providing timely information for our patients with dementia and caregivers, so prepare them for what to expect and how they can plan for themselves and their care, be very proactive, in other words. So me and our team of case managers, we roll out regular workshops for patients whom we serve from the moment of recruiting with diagnosis at different stages. So we run workshops for stage-specific persons with dementia. Finish, thank you.
Well, thank you very much. Okay, why don't we take V's question as well, and then we'll pose various things to the panel. So please go ahead.
Thank you. So just want to thank Michelle, as well as Dwayne and Wei-Ling. And I want to share my perspective, which I think reiterates many of their points, but it's also a different perspective. So just by way of background, I'm a part-time worker at a senior daycare center, and so I've been doing this for a year now, and I see a lot of elderly people with either dementia or pre-dementia in a maintenance setting. And I wanted to say that, you know, all the cases I've seen so far seem to segment whereby, I know Wei-Ling doesn't like the term, but they use the word caregiver and informal caregiver, which implies that their role is informal, it's ad hoc. But from what we've heard so far from Michelle, her caregiver is actually an integral part of a team. And I wonder whether the narrative needs to change to help us recognize that no single person can provide adequate care for someone with dementia. So instead of calling them caregiver, care partner, maybe we need to think of it as a team, the team lead of that care group. Because I think the studies show that it takes on average three people to care for a person with dementia, not necessarily full time. And that's where I'm coming towards, which is that if we deconstrain ourselves by assuming that it's got to be a primary care partner responsible for it, then maybe the solution becomes, as Prof. Chin said, more sustainable. And to that point, I guess Michelle raises a very good point, and as did our colleague who says that sometimes the helper knows better than the family. Why is that? Because they spend a lot more time with the client or patient. And in fact, JJ acknowledged as much. Sometimes the doctor just asks the domestic worker about the condition rather than the patient. And I actually see that happen at my center too, because sometimes when we see a client is not doing well, we don't bother to call the family, ask them how they're doing. We just ask the helper, how is Amma? You know, what's she been doing? Did she sleep well? Has she been taking a medication? And so that actually leads to the other point, which is that it's not a bipartite care partnership. The day center is actually part of the resource team as well. And we've been encouraging the families to actually tell us when their loved one is going to see a doctor for the geriatric or psychiatric appointment, because we have inputs we can give them, which may be helpful and supplementing what the caregiver does with the patient, because we see them for the best part of 6 to 8 hours every day. But I think that relationship hasn't been quite recognized or hasn't been utilized as well as it could be. So I guess the point here is that many hands make light work. And second point actually is the issue of delegation versus abdication. Quite often, as Jason mentioned, some families will employ a helper, put their elderly one in a flat, and then dust their hands off and everything's taken care of. But we all know it isn't. And actually, in the course of conversation with many old people, I realized that they're actually depressed because they're deprived of time with their family. And I wonder, this is a question, not a statement, I wonder to what extent that's an unintended consequence of MOH subsidy means testing. No, I'm serious, because for those who don't know, the medical social workers can tell you that the means test basically tests the household income. And so if you move your Amma and Akong to a different household and put them in the domestic helper, they have zero income, and automatically they qualify for maximum subsidy. And so the unintended consequence is that families, because they cannot afford it, will move their family member out. And then when they're out of sight, out of mind, they wash their hands and becomes abdication instead of delegation as part of a team. So that's just a question. I don't know what, maybe the MSWs can comment on that. Have you seen that happen often? Because I have a sneaky suspicion that's happening, but obviously I can't go to the client, hey, did your daughter kick you out because they need to pass the means test? And first of all, they have dementia, so they can't tell me, but I don't want to make it feel any worse than that. So yeah, those are my 2 points. Thank you.
Thank you. Wow. That's a lot of food for thought, right? In relation to how systems are structured, how it really requires multiple people to be involved from the different professions, as well as your family and care partners, to be involved in the care of somebody who has dementia or other issues in relation to cognitive issues or frailty. Also, I think, interestingly, when we were talking earlier on with Philip and Dwayne, we were looking in relation to how conversations could be framed, but then there's also ethical issues involved in nudging, right? In persuasion, and when does that sort of nudging or persuasion actually become a little bit too much and not acceptable in that situation, right? So these things are all very complex and difficult, especially when you are thinking about the best interest of the patient and you think you might know or have that in your mind and you're trying to nudge them in that direction, but how far do you go in relation to that? Chair's privilege. I'm going to direct that question maybe to JJ first and then to Philip, because I don't know whether you have the same perspective, but it'd be interesting to hear both of you on that before we move on to the second case.
What was the question? They say that if you can't answer the question, then you answer the question that you want to choose to answer. But I'll leave that to Philip. But I thought I'd just make a comment that I think King V is right in that no one person can provide the care, the good care that we have come to expect. Not just in terms of resources, but in terms of stamina, in terms of sustainability. I think, when we moved our population from the kampungs years ago into HDB flats, I think there was a secret hope that some of these kampung spirit will be continued in some of the HDB flats. But I think that it was there, but I think with generations where people... So what we have come to realize today is the sort of... What is in conflict is that our society is very high, fast-paced. The young people leave their home in the morning, they rush to work, and they come back in the night. Many people nowadays do not know who their neighbors are, and so forth. I remember a story of one of my patients. She was... They came from Malaysia to consult me, but when Granny was in KL, KL being perceived as such a dangerous place, what they do is they always lock the gate, they lock the door, and Granny was in a terrible state, requiring lots of antipsychotics and all that. Every day she'd go to the gate and shout for help, telling people that she's been kidnapped and all that sort of thing. So in the end, the son gave up, and he sent her back to her home village. And lo and behold, she had a few good years at home village, because what happens, they told me later on, is that she would wander out of the house. But then there was hardly any traffic in the village, and the fastest vehicle there was probably a bicycle, yeah. And the interesting thing is that because everyone knew her, wherever she is during lunchtime, they would give her lunch. And then wherever she is at dinner, they'll give her dinner. And somehow, without even signing any service agreement, the fellow villagers would bring her back to her home in the night. And she had a few very good years, yeah. So I guess, really in some ways, the pathological aspect, the challenges, the handicaps, they become very prominent in an environment that's very hostile. Like today, we ask ourselves, do we have a neighborhood that helps to support persons with dementia? Do we have a community? When a person with dementia wanders out of the house and is trying to cross the road slowly, what does she get? She gets a car honking her, and that's already very fortunate. It doesn't knock her down, right? Yeah. So I think the question then is actually how then do we provide a safe space for them to yet meet some of the needs? It's not going to be easy. It requires resources. But as this becomes a prominent problem in society, then I think we really need to ask ourselves then, how do we collect the disparate efforts from each of these locked up HDB flats, pool them together? Yeah. There is also a suggestion about time pooling, meaning that, if a community trusts one another, today I'll look after your seniors for 2 hours, I clock that, and we clock it forward. Tomorrow, if you have a crisis, an urgent need to rush to the hospital or rush to your work, then you could then lodge your seniors with me. I think we need more and more of this sort of, and I think we need, in fact, in some ways, we need also leadership initiative in the community that is not government-driven. I think in Singapore, we also have a culture of relying on the government for everything. I think the community needs to step forward, such as Dementia, the Alzheimer Singapore, and Dementia Singapore and all that. We need to be able to come up with these sort of arrangements. But we realized to do that, we first of all got to bring back that community spirit, to build trust and so forth. And so, you know, we need more kepos in the community to go around kepoing, but these are the people who will then, they are the sort of grapevine, and they link people in the community together. A lot of these are easier said than done, but we have seen some of the very anecdotal, successful stories in some of these communities. But the question is it scalable? Is it, you know, that is something that we often wonder. But, you know, when you talk to a group of people, they all say, hey, we want to help. But I think it's how we organize that into, ironically, not too formal, and yet, you know, something that that the communities can look into.
I think it's I mean, coming back to the nudging question, I'm privileged to have had a bit of time to think about it. So it's a good thing that you went first, JJ. Yeah. But just taking that issue about making our communities senior and dementia friendly, I think there are many efforts around Singapore. I think Dementia Singapore is leading many of these efforts. My question has always been, how do we assess the maturity and the success of these efforts? Yeah, how do you do, like, when is it appropriate, and how do you do like a pulse check to see how well we are doing? Are we truly dementia friendly or senior friendly after 5 years, for example, of a campaign? Yeah, so I think that question needs to be answered before we can even say they want to scale the efforts, right? Are these efforts actually bearing some fruit already or not? I think that has always been my question. So coming back to the nudging issue, actually, I think the first thing I must acknowledge and admit is that as clinicians or as healthcare professionals, we negotiate and we nudge all the time. Because most of us would have a particular stance on what is appropriate. Sometimes I would say it's a mix of best interests of the patient, but also some self-centered interests too. For example, as a clinician, do I advocate for a particular form of treatment for this patient that would have side effects that are real? So, or do I take a neutral stance and, you know, leave decision making to the patient and the family? But within ourselves, sometimes I guess we most of the time would have some awareness of what is perhaps workable and feasible and appropriate. So in the case of dementia, I think first, in order to be able to move forward with what is in the best interest of the patient, we first must then acknowledge that, or must try to understand what the patient truly wants. Right? So it cannot be paternalistic. So we must make the effort, like in treatment considerations or advanced care planning, to know the priorities, goals, preferences, values, concerns, worries of the patient, and what's really important for him. And with that kind of awareness, then decide, maybe also in conversation with his close family members, on what might be really best for him. And once we have that clear, then perhaps then it might be appropriate to try to nudge the person towards a certain end, a certain goal. For example, right, for the safety of the person, just from the example just now, it would really be risky if the person goes out and gets lost, and, you know, maybe, you know, something untoward would happen to that person. So we think it is perhaps in his best interest that there's some form of, or some way to identify him, or some way to track him might be appropriate. So how do I then work towards that goal, if that is what we think is best? And having also heard from him that he still wants to live his life, to thrive and to grow despite dementia, how do I help him achieve that goal? Because that cannot be reached if something bad happens to him. I think this is how I think I would think about this. Yeah.
You know, I just wanted to answer the question about the subsidy thing, right? Ping Hui, is it? You know, I think it does happen. I'm quite sure it does happen, because we have heard, you know, now the subsidy from the government is based on the household of where the elderly is staying. We have heard of cases where the elderly has three children.
they put the address of the elderly with the sibling that has the lowest income so that they get the maximum subsidy, although dad or mum may not be staying in that household. So if that happens, then I'm quite sure that making them stay on their own with a helper is definitely something that is possible, and I think it does happen. And I really like your concept of a teamwork, because it really needs, you're right, you can't rely on one person. Your burnout is not sustainable. So the teamwork is very important, which is why I come back to Ka-Ching's question about, I also acknowledge that a helper is definitely key, because without a helper, it's very difficult. Again, teamwork, right? But to park the person with dementia and the helper in a separate household away from the family, I think that's where I said it's no. But having a helper, I think that one is definitely something that we need. Because I know that when you park them in a separate household, you will visit your mom or dad maybe once a week, twice a week. You'll get down to once a month, and maybe never at all. Because work sets in, you're busy, you come back from work at 9 o'clock, you're having a dinner at 9:30, the last thing you have on your mind is driving another 20 minutes over to see mom or dad. It will never happen. And then the weekend comes, and then the kids have events and things like that. It never happens again. So that's what I meant by parking them in a separate household and really just relying on the helper to take on that burden of caring on their own. That's probably not appropriate. Yeah, thanks.
Thank you very much. Excellent perspectives. So if it's okay with everybody, I was thinking of moving on to the second case. So if we could have that up on the screen, you'll be fine. There is a second case. So I'll read this one out. Mr. Koo, yes, is a client. JJ's pretending not to remember the case. I'm sure he remembers the case perfectly. Mr. Koo is a client at an active aging center near his home. His wife and children decided to enroll him there after he suffered a major stroke that left him with weakness in one half of his body, problems with balance and coordination, and mild cognitive impairment. At first, unhappy about the decision, Mr. Koo has recently become motivated to exercise and maximize his potential for stroke rehabilitation. He tells them now that he looks forward to being at the center. One morning, the center manager calls the occupational therapist and care staff responsible for Mr. Koo into her office. The center manager tells them that Mr. Koo's wife had just telephoned her to say that all rehabilitative exercises for her husband, including help with standing, must be stopped. Mr. Koo had fallen several times when he tried standing up at home. She was worried that he would suffer a catastrophic injury if this continued. When the two staff protested, the center manager tells them that she has no choice but to follow the family's instructions. The two distressed staff, having been warned not to tell Mr. Koo about his wife's telephone call, are unable to explain to Mr. Koo why they are not proceeding with the usual exercises. A frustrated Mr. Koo becomes angry and shouts at the staff. He does not return to the center after this, and weeks later, when the manager calls Mr. Koo's family to check on the client, she learns that he's been hospitalized for a skull fracture. Okay, what a case. Maybe before we start with the panel, I was wondering whether anyone in the audience had any reflections, comments, or questions specifically about this case. Please don't be shy. You haven't been so far, so that's great. Yes, please.
Good morning to all. My name is Paul, and I'm an informal caregiver with a little bit of experience. So for pharmacists who have many years of experience, you know that 10 mg memantine from 370 in 2007, not inside MOH SD1, SD2, MSF has dropped. And I'm glad that the ethics committee or whichever MOH committee has dropped the price to 40 cents now, on 12 cents now. So I have enough experience to look after a vascular dementia mother-in-law, and also a unique case where I have a sister-in-law with YOD. living in the same household. So enough experience to share some of this that resonates with my mother-in-law. And she really lives, goes to the GDDC Monday to Friday for a number of years. And then she suffered a stroke. And the discharge summary, I guess all the doctors here will know, you do an MBI, and her score is below 25. So under MOH guidelines, GDDC and IHDC gives you the liberty to reject a client below 50. So now, as a caregiver, informal caregiver, I would like the ethics committee and the chairman and Prof. Jing, and I'd like to borrow some of your words. It's oversimplified for GDDC and IHDC to immediately reject a client based on the MBI score. Less than 50, you can reject. So my mother-in-law enjoys going to the GDDC to do her painting and etc. And we are very fortunate to have my sister-in-law and mother-in-law going to the same GDDC. How difficult for the same household to go to the same GDDC. So in this case, now, we have to so-called really satisfy my mother-in-law's own desire that she really enjoy the people watching, so-called. She's not ambulance, she's on wheelchair. So this MBI score, I would say that it's time for a change. It's oversimplified. So for all the professionals here, when you do your discharge summary, your MBI score, you'll notice bathing, bed change, chair, wheelchair transfer. How many of this is being used in the GDDC or in the IHDC? I don't think so. So you should not be oversimplified that for a center to just reject. Because for this, I have to do some creative violations, so-called, at the hospital before my mother-in-law got discharged, because I have to go and dig out and read up all the MOH guidelines. That this MBI index is the major key criteria. So I have to violate one of your hospital's use of camera. Before my mother-in-law got discharged on the day for the last so-called lunch, I video her. She's fully capable to use the other hand to feed herself. And she looked bright and she can take her own coffee and tea breaks and all those things. So with that simple MBI index, she was rejected outright before she was discharged and go to the community hospital. So I had to take this video, send in and then do a case argument with the center. So in terms of policy making and this conflict between daycare and care at home, my mother-in-law will definitely enjoy and has a better quality of life at the daycare center because she really enjoy and she look forward to it. And if all the MSW and your case doctor would definitely say that if the GDDC don't accept you, then you go to IHDC. I guess all the professionals, if you step back and becomes the child, you know that that is the downhill spiral. Just one step away from nursing home, it's going to be worse. So how can we, because I like to read up on your journals and challenge the MOH guidelines, so I'm able to go and do all this work to argue with the GDDC. There are many others who will just take the rejection outright. Same for this, who's going to take care, who's going to decide for that? And if the injuries or these things, okay, fine. I actually have to get a helper to go with my mother-in-law to the GDDC. So all the toileting, transfers, feeding is all negated from your MBI score. Then why don't the policymakers now please take a look? It's time to look at some of these guidelines that has been in the 80s, I believe so. If I look at the MBI score and the write-up. So Emily is one of my role models. She likes to read journals. I also spend some time to read through. But more than that, I read through the MOH guidelines and the AIC guidelines too.
Thank you. I mean, that must be voluminous. You're very dedicated, obviously. I mean, I think JJ is asking for the microphone, so I'm going to pass the buck to him.
I'm just going to make a few comments. First of all, I think, I think we also want to empathize with policymakers, because it's not easy to do guidelines and all that, because eventually you have to cut somewhere. And the question is always how sensitive or specific your instrument is. Sometimes you sacrifice sensitivity, you get specificity. Sometimes it's vice versa and all that. And also the cutoff is often taking into account the amount of resources they have and so forth. But I think that what your case highlights is that there are always exceptions. Yeah, but even before that, the question I think that I want to ask, or rather perhaps the observation I want to make, is that I think these functional scores like modified Bartel and all that, they can be very dynamic in the acute phase. Patients do recover from a stroke. The question is, are they up to date? Yeah, and the other thing is that, the weakness of a lot of these things is that it is a composite score. It doesn't tell you exactly what the details are, because sometimes somebody may be very high scoring in a particular function and not so in another. And I think that along the way, there are always some who slip through the cracks, and you feel, especially particularly with the care provider, care partner, you feel the injustice and all that. So I think appealing on a case-by-case basis is the right thing, because there are always exceptions. Yeah, a lot of times policies are made based on the majority of the cases, and they just cannot handle some of these exceptions. So what needs to be done a lot of times is ensure that there's an up-to-date assessment, that the MBI score is up to date. It actually reflects the patient's current state of ability. And if your mother-in-law has recovered to the point where she can do all these, then I think the MBI score is no longer what it was when she was discharged. And if the patient stays for a certain period in the community hospital, then it needs to again be refreshed at the end of it. And we know that for a fact that many of these patients, especially acute stroke, do, unless it's a very massive stroke, they do have recovery in either their FIM score or their MBI. And that needs to be updated. In other words, the agency that we have applied to for maintenance care, the community needs to know that. And of course, the last resort, as you said, you actually videotape her and to prove that she has improved enough to be able to go to. So I think we need a system to govern the majority of cases, but we do also need a system that allows some of these exceptions, as long as we are able to prove that the patient is able to benefit. I think that bureaucratic rigidity is not the way to handle some of these cases. But I don't speak for the people who administer these policies, and therefore I can't help these cases. But I think I commend you for the effort that you have gone to in trying to prove the case, in trying to advocate for your mother-in-law, because I think that nothing is worse than inactivity after a stroke, particularly for patients with dementia.
Sorry, Sumi, can I just respond to that gentleman's point?
Sure.
I fully sympathize with him, because we see a lot of that, or I've seen a lot of that in 12 months. And I want to say that his experience, I just want to say that in the center I work at, and I know this is atypical, this is why I have the privilege of working there, the center manager takes on the initiative to make that decision on a ground level. But I can tell you it's not easy, because she gets dinged all the time on her KPIs. And Martin said that yesterday when I asked him. He said, we want them to drive up the capacity utilization, because otherwise we are wasted spaces. The problem is that for that gentleman's mother-in-law, if we discharge her, we can put a higher functioning client, we can get our utilization up. And so my center manager's position is that she'll come and ask and say, so-and-so is due for a discharge. Are you guys prepared to put in the extra effort to keep her in? And because she's been with us for 8 years, we all recognize that her family loves her being in the center, so we make the extra effort. And I guess, to be cynical, we all know that our bonus isn't going to be big, so it makes no difference. It's not like we're going to get 18-month bonus if we hit our KPIs. So we just say, look, the reason we're here is we're going to do the best for these people, so forget the bonus, let's just run it safely and keep her. And one other thing I want to say to those MSWs or people who have pet loved ones who are in these centers, there's always a negotiation. How we sometimes get around this is if the client has come with a stroke, I had a recent stroke and she's her functional ability is temporarily declined, the manager will ask, can you send your domestic helper
to us to sit with her so that when we do the toileting, we don't have such a big burden. Because like it or not, if you're half body weakness, we do have to transfer you to a toilet. Whereas if we take a fully functioning client, that saves us 10 minutes. And so if you multiply that through a number of clients we have to look after, that's significant. And so that's how we get around it. I mean, but it takes leadership and it takes courage from the manager to accept that she's going to get a bonus and KPIs cut because she's going to make the right decision for that client. How many of our people have that courage to make the right decision? And she doesn't do it alone because she asks us, because she knows our bonuses are going to, well, actually I don't get a bonus, I'm an hourly rated worker, but everyone else's bonus gets cut. So that's what I would say. Don't give up, just keep pushing at it, because JJ is right, the policies are designed that way, and the policies actually drive behaviors which look for efficiency, but as I always remind myself, efficiency is not the same as effectiveness. They both begin with E, but we want to be effective, not necessarily super efficient.
Well, thank you. Yeah, I mean, certainly a lot of challenges at the policy level, and I can see Roy would like to say something. Sure. Can we get is it possible to get a, oh, you're prepared to, okay. But before you pose your question or comment, Roy, I just want to mention to Wei Ling and Dwayne that after Roy's comment, what I'm hoping to speak to you about is looking at that tension between managing safety versus protecting autonomy, right? So especially as, not just only now, but perhaps as the condition progresses, where you see that balance could be struck, you know, in terms of where that scope would be. So if I just leave you with that thought, and Roy, please, we would love to hear from you.
Thank you. I'd just like to bring us back to this particular scenario in front of us. There's something here that actually troubles me a lot. It says that the question to the panel. Why are the therapists and the center promoting Mr. Khoo's stability and flexibility? Is it not because they also fear that without it, he will fall and suffer a catastrophic injury? Number one. Number two, in a way, when they are doing all these, they are just extensions in a way of medical care. They are acting in his best interests. There's nothing here which says that Mr. Khoo has no decision-making capacity. He's just had a stroke. So, when Mrs. Khoo now calls and says, you must stop, is it not wrong that the center manager tells his staff to stop? What authority does Mrs. Khoo have? Mrs. Khoo can provide an opinion. Look, he's becoming very adventurous. You have given him a certain degree of stability. Are you sure it's okay? But really, do these professionals need to just bow down before her demand and then negligently lapse in their care? Thank you.
Okay, Roy, maybe I just have a quick response here. I think in most cases that I've seen, these are cases where the patients or the persons with dementia do not have insight. Yeah, and a lot of them have impulsive behavior. So as far as they're concerned, so you could test that by asking them about, you know, what do you think is the risk of you falling down? They'll tell you, I won't fall down. Yeah, so you know that capacity there is a little bit questionable. I think if Mr. Khoo had capacity, then it's a very different sort of, takes you on a different course of discussion. Yeah, but I think what we have in this case, before Wei Ling and Dwayne give their perspective, is that what we have is a choice between something that is a danger that is imminent and immediate, but which which requires, if you still want to accommodate ambulation, which requires a lot of energy and attention from the care partners and the care providers, versus one where the ill effects of immobility are much more insidious but they are nonetheless real, yeah, but which requires less attention and energy. You know, in one case, you either have to, so for us, I think since I was a junior doctor, we've seen that already. We rehabilitate the patient, you know, they've quite good MBI scores, and when you see them 6 weeks or 2 months later in the clinic, they are strapped to the wheelchair with, you know, wasted muscles of the legs, because the family will tell you, no, I just can't afford, because if you were to fall, the consequences are catastrophic. You know, I would have to stop work, I would send him ambulance, and goodness knows what the impact on the family, and it's far safer for him to be non-ambulant on a chair. That's many times in spite of the explanation about some of the longer-term ill effects of not ambulating. And of course, the person, because he's struggling, he wants to walk, then the person is tied down, and you have all the issues of pressure ulcers and, you know, urinary tract infection, constipation, and all sorts of things, yeah. But to a lot of family, this is longer term. I got to solve my immediate problem now, yeah. And therefore, well, raising awareness and education is one. We've always have spent time talking to family about, you know, if you don't walk, you know, it's going to be a one-way thing, because the muscles will go to waste, and you can start with other issues. But I think I do empathize with some families, because they only have enough energy. They're treading water, so they only have enough energy to see the immediate problem, and they are, you know, I'll deal with the later problems later on, and therefore, you know, here is a real challenge. It's a very real challenge, and I think we want to hear from Wei-Ling's side, you know, what is the perspective, and how do you find that sweet spot? The doctors and nurses and the healthcare professionals always want to help. If you find a certain sweet spot, we'll try to help. But certainly, I think we also understand what a lot of families go through, and it is not that they neglect the best interest of patients, but they can only solve one problem at a time. So I think we're still trying to find our way to help support, and I suspect sometimes the solution may be in technology. We may have to find, you know, if the patient will stand up, an alarm will go off, and then, you know, so that you don't have to pay attention to the patient all the time, but when the alarm sounds, you should put down whatever you're doing to try to help the patient. And I think that's still work in progress.
Okay, I'm not going to sell Koyo, but I want to say a bit about Caris Ace Activity Center for Elders. I used to volunteer there, and their goal is to have the elderly help another elderly as they age gracefully. So it's not it's not a nursery home, daycare, it's a club, so to speak. So Dwayne and I recently kind of got some training from the physiotherapist, which felt that the elderly need more exercises. Like, you know what we say, you don't use it, you lose it, right? So when I saw this case, I asked her, I took the opportunity to ask her, so what do you think about this? She said they will find out why the family is against, especially for this case, Mr. Koo enjoys it and seems to be able to, you know, and it helps to strengthen. So those exercises are also improvised for those who are in wheelchair and those who are able to stand. You know, remember we were doing all those, even like dropping this water bottle, you know, catching it, so to train our grip. And as we age, it becomes less mobile, right? So we were doing it, and she was saying what we want is to empower them, have them train themselves, and challenge them to the state that they can do it. They were playing badminton already, you know, start to do all these kind of things. So again, now I know I'm a care leader of the team. So with care, you do need to put in effort. The easiest again is to like sit in a wheelchair, don't do anything. But in this case, he fell down at home. It was because the muscle has weakened already. And then all the more weakened further when he doesn't, you know, exercise every day. When we go to our social club, Young Onset Dementia Social Club, we will do some meditation and then exercises, and in the hope of we will do it every day ourselves as well, So in this case, I think because I heard from this Jacqueline mentioned before, V Center, they have this policy, no fall policy, because they have to write long reports. Again, the sweet spot of benefits and risks. It's true, we still haven't, or at least me, not able to convince my mom and dad to do exercise. Maybe another third person, professionals. That's why I said it takes a village. It takes a village to not raise a kid, but also to look after a person with dementia or other condition. So sometimes they might listen to a third party, because the daughter always nag at me, he sometimes also she's always nagging me, because I think cognitive exercises are important, and he's like, yeah, word search, so boring, right? So anyway, back to us, communication. There's no safety issue right now. Firstly, he doesn't cook, he doesn't use the stove, which is good. But I have a problem, because since I'm a teenager, I burn kettle on the stove, because I'll forget. Okay? So what do? I change to electric ones that turn off by itself. So these are the coping mechanisms which I adopt, and we will have to adopt should Dwayne progresses, God forbid, but it might, okay? And I learned from other care partners or other cases where knives are put away. For cases where they have delusion and hallucination. So knives are put away, signs are placed where the toilet is, because they cannot recognize where to go to the washroom. So having that village, the community, sharing of all these tips, I think is important to find solutions, okay? At the same time, I think building that trust relation. Dwayne lived on his own, and I lived on my own for years. I actually sold my flat and moved to his flat, okay? Because he needs that support, okay? Again, it does take effort, okay? But I also remember, when I help him, I'm helping myself too. Like the goal we set to run 3 times a week, sometimes I don't want to do it because I really hate it. He hates it too, actually. But we say, no, it's our goal, we have to do it. And then I push him and he pushed me. So he helped me too. So it's a two-way thing. That's why they are empowered. So for physicians when you see your the partners, and you can tell when I see him keep repeating, I know when to intervene, okay, because of that relationship. So early diagnosis, early intervention is very, very important. I think Michelle highlighted that as well yesterday. And the helper is there as part of the village, not the village by itself. So all, together with, like the employment SIG we're talking about, Dementia Singapore is supporting us. We are not saying, Dementia Singapore, please, do this. It's the PWDs, the advocates, care partner advocates, and NNI now we are looping in their support because they are looking into that program. Else? Do you want to add? I talked for a long time.
I think you finished it.
So it helps also because I'm the older sister. You can tell, right? Older sister. So if I mean, for some who, yesterday I was talking to someone, the father has frontal lobe. So it might be a bit more challenging. So you have to adapt and adjust your method. Yeah, so it's really case by case. And then, but very importantly is he has to be involved in whatever that's suggested, because he's a person, no? So we have to, like what we always learn, separate the condition and the person. He has 30 years of flying experience, okay? That is a big part of him. We don't focus on the disability that he has now. We focus on the ability he has. And all your loved ones who are going through the journey of dementia, it's very scary for him. Okay, before we found out what was going on, it was very scary for him, and he was on his own. So I think when we watch out for each other, the village, the kampong, and I also have example of this, which my friend said, sent her sister back to Malaysia and she improved. So that is very important. We live in a very stressful society. I retired, so yeah, maybe I'm a bit itchy already, so maybe I will look for something. But the employment special interest group will be something that is very interesting, something more meaningful. So, okay, I can go on and on, So I will stop here. You sure you don't want to say anything else?
I see enough.
I just want to make a comment that, looking at this case, the aftermath, I think, a very frequent scenario we see is actually, witch hunting, who to blame and that sort of thing. I think it's important that we manage this kind of cases where we must try to rid everyone of the sense of guilt, because these are decisions, either decision comes with their own risk. And I think once you've made the decision for the right reason, you move on. But a lot of times we find that a lot of family members, if they are the one who, for example, advocate walking, they would now be blamed by the rest of family for advocating walking, and then thereby causing this skull fracture. And therefore, it is important, and sometimes I find that healthcare professionals do have a role to come in, to mediate, and to be able to articulate clearly that, that we shouldn't be putting the blame on the person who made the decision, because every decision comes with their own pros and cons. Yeah, otherwise it would lead to a lot of breakdown in relationship and a lot of anger and so forth.
Well, that's excellent. I'm not going to hold anything up anymore because, well, we're looking at the time. But before ending, a couple of things. One, to very quickly say, and actually to follow up on JJ's point, the solution isn't legal either for this case involving Mr. Koo, for those of you who are interested. I mean, what are you going to do? Call up and say, the patient has autonomy, I'm going to disregard what you want. I should be asking them what they want. It creates problems, because all the family will do then is probably just take this person out of the care center and put them somewhere else where they're not going to be doing the exercise. So, that sort of communication and engagement with the person with dementia or person with frailty, as well as their family, is very important. And to a large extent, I think healthcare professionals do need to take the lead on that, right? To initiate those discussions, to provide advice, to have these discussions. And that's the other theme I want to also highlight, the importance of communication with not only the persons with dementia, to the extent that they can be involved, respected, and involved, in making decisions for their own healthcare, especially initially when the condition is not very advanced, but also involving the family members, trying to build that supportive network to enhance the person with dementia's autonomy for as long as that is possible. And we also had very good conversations, or rather a very good talk this morning from Emily, who looked at things from a more aspirational perspective as a person with dementia. And then we had JJ's talk looking at more macro issues, right? The bigger picture in terms of policy and how we might be able to marry these two together, especially when looking through the lens of the care partner and the health system and the limitations and trade-offs that we have to make in order to create a system that works in the best possible way for our community. So I think we've had a very, very rich Yeah, of course. And yeah, JJ so kind. And of course, we've had very good contributions from both Jason and Philip, who have, again, shared the wealth of experience in relation to caring for people with dementia, having good communications and advanced care plans with them, setting up community programs that would benefit everyone, right, in our community. And of course, Wei Ling and Dwayne, who have been very generous with their time and shared with us so much about their experiences and perspectives, which are very valuable to all of us, I think. So a very big thank you. Have I missed anybody? I hope I haven't missed anybody else. Oh, you wanted to say something. Okay.
No, it's okay. I think maybe just a brief comment, because I was particularly touched by what Wei Ling said when she said we have to adapt and change. I think that kind of sums up quite well what we are trying to do here. I think in a caregiver and caregiving partnership, it's the more resilient, or for lack of a better word, successful caregivers are those who say yes to this responsibility and are able to adapt and change for the sake of the person they care for. Because the person with dementia cannot change for us. We have to change for their sake. In the same way, I think the healthcare system at a macro level would need to adapt and change to the changing environment of our population with aging issues for the sake of the citizens, aging citizens and caregivers and people with disabilities, dementia and frailty. I think this is perhaps a good way to kind of sum it up, isn't it?
Thank you, Philip. Sorry, I didn't get JJ's nudge that you wanted to say something. Maybe the solution is we should all go and retire to some kampong in Malaysia. But if we can't do that, I suppose we'll just carry on. But I don't want to hold you up for lunch. Before I tell you that we are hopefully going to return at 1:40. I do want to say thank you very much to everybody on the panel, and if you could just join me in a warm applause.